Right now, over 6 million Americans are living with heart failure. That number climbs every year, and the majority of those patients are over 55. If you are one of them, there is a very good chance you take Metoprolol, Carvedilol, or Entresto every single morning. You swallow the pill, wash it down with coffee, and move on with your day without a second thought. Here is the problem. Most people on these medications have never been clearly told what the drug actually does inside their body, why it was chosen for them specifically, or what common mistakes can make it less effective or outright dangerous. This is not about scaring you off your medication. If your doctor prescribed it, there is a reason. But understanding that reason, understanding how the drug works with your body and how certain daily habits work against it, that is the difference between a medication that protects your heart and a medication that quietly underperforms for years while you assume everything is fine. Nobody has time to explain this in a 12-minute office visit. That is what this video is for. By the end of this video, you will understand your heart failure medication better than most patients who have been taking it for a decade. But first, we need to talk about what these drugs are actually fighting. Because the term heart failure is one of the most misunderstood phrases in all of medicine, heart failure does not mean your heart has stopped. It does not mean your heart is about to stop. It means your heart muscle has weakened to the point where it can no longer pump blood with enough force to meet your body's demands. Think of a garden hose connected to a faucet with low water pressure. The hose is fine, the connections are fine, but when you turn it on, the stream barely reaches the flower bed. That is a failing heart. The pump is running, but the output is not enough. When the heart cannot push blood forward efficiently, everything upstream starts to back up. Fluid collects in the lungs, which is why so many heart failure patients feel short of breath doing things that never used to wind them. Fluid pools in the legs and ankles, which is why the swelling shows up by evening, and organs that depend on strong blood flow, your kidneys, your brain, your muscles, start underperforming because they are simply not getting what they need. Doctors measure how well the heart pumps with a number called ejection fraction. That is the percentage of blood the left ventricle pushes out with each beat. A healthy heart ejects roughly 55 to 70%. Below about 40%, you are in the territory of what doctors call HFrEF, heart failure with reduced ejection fraction. The pump is weak. There is also a second type called HFpEF, heart failure with preserved ejection fraction. Here the number looks normal on paper, but the heart muscle has become stiff and rigid. It fills poorly between beats, even though it squeezes adequately. This distinction is not academic. It directly determines which of the 3 medications your doctor chose for you and why. And that is exactly where we are going next. Metoprolol is a beta blocker. To understand what that means, picture this. When your heart is failing, your nervous system panics. It floods the heart with adrenaline signals, essentially jamming the accelerator to the floor, forcing the heart to beat faster and harder to compensate for the weak output. That sounds helpful. It is not. A failing heart beating too fast is like a tired runner being forced to sprint. The runner does not get stronger. The runner collapses faster. Each beat is rushed, shallow, and inefficient. The heart never fully fills with blood between contractions, so it pumps less with each beat, not more. Metoprolol is the brake pedal. It blocks those adrenaline signals, slows the heart rate, lowers blood pressure, and reduces the workload on a muscle that is already struggling. Slower beats mean fuller beats. Fuller beats mean more blood actually reaching your organs. Now here are 3 things most patients are never clearly told. First, you must never stop metoprolol suddenly. If you quit cold, those adrenaline receptors that have been blocked suddenly open wide. Your heart rate can spike dangerously. Doctors call it rebound tachycardia, and it can land you in an emergency room. Always taper under your doctor's guidance. Second, dizziness when you stand up is a real and common side effect, especially in the first weeks. The drug lowers your blood pressure, and when you rise quickly, blood briefly drops away from your brain. The fix is simple. Stand up in stages. Sit on the edge of the bed for 10 seconds before you get to your feet. Third, and this one surprises people, the dose you were started on is almost certainly not the dose you should be on long term. The standard in heart failure medicine is to start low and gradually increase to the target dose. That process is called uptitration. But in practice, many patients are started on a low dose and simply left there, refill after refill, because nobody revisits it. If you have been on the same low dose for a year or more and nobody has discussed raising it, that is worth asking about. Now, Carvedilol If you hear your doctor mention it, know that it is also a beta blocker, but it does something metoprolol does not. On top of blocking the adrenaline receptors that speed up the heart, carvedilol also blocks what is called the alpha-1 receptor. That receptor controls how tightly your blood vessels squeeze. Block it, and the vessels relax and widen. Think of it this way: metoprolol eases the engine, carvedilol eases the engine, and widens the road at the same time. That dual action is why some doctors choose it, particularly in patients whose blood pressure needs additional lowering or whose heart failure falls into specific categories where research has shown a mortality benefit with carvedilol over other beta blockers. But that extra mechanism comes with practical details most patients are never told clearly enough. First, carvedilol must be taken with food, not near food. With food, when you take it on an empty stomach, absorption drops significantly. The drug does not reach the levels in your blood that it needs to reach. You are swallowing a pill and getting a fraction of the benefit. Second, because it relaxes blood vessels on top of slowing the heart, dizziness and fatigue tend to be more pronounced than with metoprolol, especially in the early weeks. That is not a sign the drug is wrong for you. It is a sign your body is adjusting to a powerful dual mechanism. Third, and this is critical, carvedilol can cause fluid retention and weight gain. In a healthy person, that is an annoyance. In a heart failure patient, it can mask the early signs that the condition is worsening. That is why every person on heart failure medication should own a bathroom scale and step on it every single morning. Same time, same clothing. If the number jumps 2 to 3 pounds overnight, that is not fat, that is fluid. And fluid accumulation that fast is one of the earliest warning signals that your heart is losing ground. Almost nobody is taught this. It costs nothing, and it catches problems days before symptoms do. Here is something that should bother you. When you were first diagnosed with heart failure, your doctor almost certainly ordered an echocardiogram. That test measured your ejection fraction, the number that tells you how much blood your heart pushes out with each beat. Based on that number, a medication was chosen. You were started on a dose. You went home, and then for many patients, that number was never checked again. Refill after refill, appointment after appointment. The same prescription renewed without anyone asking the most basic question: has the heart actually changed? Because ejection fraction is not a fixed number stamped on you at diagnosis. It moves. With proper medication at the right dose, regular activity and good management, ejection fraction can improve, sometimes significantly. That is not rare. That is the goal. But it also works the other way. If the condition is progressing, if something else has gone wrong, ejection fraction can decline. And here is why this matters right now. If your heart has improved, your treatment plan may need adjusting. If it has declined, you may be a candidate for a completely different medication, one that was not available or not appropriate when you were first diagnosed. Staying on the wrong protocol because nobody reevaluated is one of the most common and most preventable problems in heart failure care. Most people will hear that, feel uneasy, and do absolutely nothing. But you can take a step right now. Care Health is a free platform that connects you with cardiac screenings, heart failure monitoring programs, and clinical trials for new treatments in your area. You fill in a short form, takes 30 seconds, no cost, no commitment, and Care Health matches you with relevant options near you. The link is in the description. There is a QR code on screen. Point your phone camera at it, and it opens directly. If you are watching on mobile, tap the channel profile picture to find the link. Now let me tell you about the medication that changed heart failure treatment more than anything else in the last 20 years. Entresto is not a beta blocker. It works through an entirely different mechanism, and understanding that mechanism matters. Beta blockers like metoprolol and carvedilol help by taking pressure off the heart, slowing it down, reducing the workload. Entresto helps by clearing the flood. Here is what that means. When your heart is stretched and overloaded with too much blood volume, it releases protective hormones called natriuretic peptides. You may have heard of BNP or ANP on a lab report. These hormones are your body's own rescue signal. They tell the kidneys to dump excess fluid. They tell the blood vessels to relax and widen. They are your heart's way of calling for help, and in a healthy system, they work. The problem in heart failure is that your body breaks down these rescue hormones too quickly. The signal goes out, but it gets canceled before the kidneys and vessels can fully respond. Entresto blocks that breakdown. It lets the body's own protective signals stay active longer, so the kidneys clear more fluid, the vessels stay more relaxed, and the heart operates under less strain. The clinical evidence behind this drug was landmark. In the major trial that changed practice, Entresto reduced the risk of cardiovascular death or heart failure hospitalization by roughly 20% compared to the previous gold standard. That is not a marginal improvement. That is a significant shift in outcomes. So why is not everyone on it? 3 reasons. First, if you are on an ACE inhibitor, you must stop it and wait a minimum of 36 hours before starting Entresto. Overlapping the two can cause dangerous swelling called angioedema. Second, Entresto can drop blood pressure substantially, especially in patients already on beta blockers. Third, it is significantly more expensive than generic beta blockers, and not every insurance plan covers it easily. One more thing your doctor may not emphasize enough. Entresto affects how your body handles potassium. In combination with other heart failure drugs, potassium levels can creep up silently into a dangerous range. Regular blood work is not optional on this medication, it is essential. Here is a reality of medicine after 55 that nobody sits you down and explains. You are almost never on just one medication. The average heart failure patient over 55 takes 4 to 8 different drugs daily. A beta blocker for the heart, a diuretic to pull fluid, maybe Entresto, an ACE inhibitor or ARB, a statin for cholesterol, something for blood pressure, something for arthritis, something for acid reflux. Each of those was prescribed for a good reason, often by a different doctor, at a different time, with a different problem in mind. The question nobody asks is, how do all of these interact with each other inside your body at the same time? Start with the one I see cause the most damage. NSAIDs. That means ibuprofen, naproxen, the pills millions of people reach for every day for joint pain, back pain, arthritis. Here is what most seniors do not know. NSAIDs directly counteract heart failure medications. They cause your body to retain sodium and fluid, the exact opposite of what your diuretic and your Entresto are trying to do. They raise blood pressure. They reduce blood flow to the kidneys, which are already under stress in heart failure. You can be taking your heart medications perfectly and have an over-the-counter pain pill quietly undoing the benefit every single afternoon. Next, potassium. If you are on Entresto or an ACE inhibitor, your body is already holding on to more potassium than usual. Add a potassium supplement on top of that, or start using a potassium-based salt substitute because you heard regular salt is bad for you, and levels can climb into a range that affects your heart rhythm. That is not a mild concern. Dangerously high potassium can cause cardiac arrest. Even certain antacids can interfere with how your heart medications are absorbed if taken too close together. The 12-minute office visit does not allow time for a full medication reconciliation. Most patients have never had a single provider sit down, look at every pill they take, and check each one against all the others. That gap has real consequences, and it is on you to close it. Now let me walk you through the symptoms that mean your medication needs adjusting. Because this is where the real damage happens silently. Most people on heart failure medication assume that if nothing dramatic is happening, the drug must be doing its job. That is not how heart failure works. This condition can worsen gradually, and the early warning signs are easy to rationalize away if nobody has taught you what to watch for. The first sign is how you sleep. If you have started waking up short of breath, or you have been adding pillows over the past weeks because lying flat makes it harder to breathe, that is not a comfort preference. Doctors call it orthopnea, and it means fluid is backing up into your lungs when gravity is no longer helping drain it downward. That is the heart falling behind. The second sign is the scale. We covered this with Carvedilol, but it applies to every heart failure patient. A sudden gain of 2 to 3 pounds over 1 to 3 days is not food weight. That is fluid your body is retaining because the heart cannot keep up. If your ankles or legs are more swollen in the evening than they were a month ago, that is the same process showing up visually. The third sign is fatigue, but not ordinary tiredness. This is a heaviness that sleep does not fix, a feeling of being drained at rest, not just after activity. It means your organs are not receiving adequate blood flow. The fourth, a new dry cough, or one that has been getting worse. This is particularly important if you were recently switched from an ACE inhibitor. The cough can be a side effect, but it can also signal fluid in the lungs. Your doctor needs to know. The fifth, a resting heart rate consistently below 50 to 55 that comes with dizziness or near fainting. That may mean your beta blocker dose is too high. Here is the pattern I see over and over. Seniors experience these symptoms, blame them on getting older, and never mention them at an appointment. They tolerate them in silence. That silence is one of the most common reasons heart failure progresses from a manageable condition to a hospitalization that could have been prevented. Your medication can be perfectly chosen, perfectly dosed, and still fail you. Not because the drug is wrong, but because your daily habits are working against it. Start with sodium. This is the single biggest saboteur I see in heart failure patients. Your diuretic is trying to pull excess fluid out of your body. Your Entresto is trying to keep fluid from building up. And then you sit down to lunch and eat a bowl of canned soup that contains more sodium than your body should process in an entire day. Salt tells your body to hold on to water. That is basic physiology. It does not matter how good your medication is if you are flooding the system with sodium every few hours. And here is the part that catches people. The salt shaker is not the main problem. 80% of the sodium most people consume comes from food where you never taste sharp saltiness. Canned soups, deli meats, bread, condiments, frozen meals, restaurant food. A single sandwich with deli turkey and cheese on regular bread can contain over 1,500 milligrams of sodium. For many heart failure patients, the recommended daily limit is around 1,500 to 2,000 milligrams total. One sandwich, and you are done for the day. Fluid intake is the other side. In heart failure, drinking too much overwhelms a heart that already cannot keep up with the volume. But drinking too little thickens the blood and puts stress on the kidneys, which are already working under difficult conditions. Your doctor should give you a specific daily fluid target. If they have not, ask. The daily weight check ties it all together. A simple bathroom scale, $20, is genuinely one of the most important medical devices you can own. Same time every morning, same clothing. You are not tracking fat. You are tracking fluid. Medication timing matters more than most people realize. Taking Metoprolol or Carvedilol at random times, or skipping a dose does not just mean you missed a day of benefit. It creates a rebound where the heart rate and blood pressure spike higher than they would have been without the drug at all. Consistency is not optional with these medications. And finally, movement. Many heart failure patients are told to rest, or they assume that a weak heart means they should avoid activity. The opposite is true. The heart is a muscle. Gentle, consistent walking strengthens it, improves circulation, and directly supports what your medications are trying to do. Bed rest weakens everything. Walking rebuilds it. I want to be honest with you about something most doctors avoid discussing until they have to. Heart failure is a progressive condition. For many patients, the right medications at the right doses combined with the daily habits we just covered can keep the heart stable for years, sometimes decades. But for some patients, there comes a point where the medications that worked are no longer enough. The heart continues to weaken despite optimal treatment. I am not telling you this to frighten you. I am telling you because understanding what comes next removes the fear of the unknown, and that fear is often worse than the reality. When medications alone can no longer maintain stability, doctors turn to device therapies. The first is an ICD, an implantable cardioverter defibrillator. Think of it as a safety net. It sits under the skin near your collarbone, monitors your heart rhythm continuously, and if it detects a life-threatening rhythm, it delivers a corrective shock in a fraction of a second. It does not fix heart failure. It prevents sudden cardiac death, which is one of the leading risks in advanced heart failure. The second is CRT, cardiac resynchronization therapy. In many failing hearts, the left and right sides stop beating in coordination. They fire out of sync, which wastes the little pumping power the heart has left. A CRT device sends carefully timed electrical signals to both sides so they beat together again. For patients who qualify, it can meaningfully improve ejection fraction and quality of life. For the most advanced cases, there is a device called an LVAD, a left ventricular assist device. This is a mechanical pump surgically placed inside the chest that physically helps the heart move blood. It can serve as a bridge to a transplant or as a long-term therapy on its own. The timeline from diagnosis to any of these interventions varies enormously. It depends almost entirely on how well medications are managed, how early problems are caught, and how honest the communication is between you and your doctor. The goal of everything in this video is to keep you in the zone where medications are enough for as long as possible. That means active monitoring, reporting symptoms instead of tolerating them, and never assuming that silence from your body equals stability. Let me leave you with the most practical thing I can give you: a list of questions to take to your next doctor's appointment. Write these down, put them on your phone, print them out, because your doctor is not going to volunteer this information in a 12-minute visit. There is not enough time. You need to ask, question 1, When was my ejection fraction last checked, and should we recheck it? If the answer is more than a year ago or nobody is sure, that conversation needs to happen. Question 2. Am I on the target dose of my beta blocker, or am I still on the starting dose? If you have been on the same low dose for months or years, and nobody has discussed increasing it, you need to know why. Question 3. Should I be on Entresto instead of, or in addition to what I am currently taking? If you have heart failure with reduced ejection fraction, and this drug has never been discussed with you, ask directly. Question 4. Are any of my other medications working against my heart failure drugs? Bring every single pill you take, prescription and over-the-counter, and put them on the table. Ask your doctor to look at the full picture. Question 5. What is my specific daily sodium limit? Not a vague suggestion to watch your salt. A number. Question 6. What weight change should I call you about? Get a clear threshold so you know exactly when a morning number on the scale means you pick up the phone instead of waiting for the next appointment. Here is what I have learned in 15 years of practice. Walking into an appointment with written questions changes the entire dynamic. It signals to the provider that you are paying attention, that you understand your condition, and that you are not going to let the critical topics disappear into small talk and a rushed goodbye. Advocating for yourself is not being difficult. It is not being a problem patient. It is being a responsible one. Your doctor does not have time to bring this up. You do. Let me bring everything together. Heart failure is not a death sentence. It is a condition that responds to the right treatment, the right habits, and the right level of attention. But you have to understand what is happening inside your body to make any of that work. Know which type of heart failure you have, reduced or preserved ejection fraction, because that determines which medications belong in your regimen and why. If you are on Metoprolol, never stop it abruptly. If you are on Carvedilol, take it with food every single time. Step on a bathroom scale every morning and know what a 2 to 3 pound jump in a day actually means. If nobody has ever discussed Entresto with you, bring it up. Watch for drug interactions, especially NSAIDs for pain, potassium supplements, and salt substitutes, because these can quietly undo what your heart medications are trying to accomplish. Do not blame new symptoms on age. Worsening breathlessness, deeper fatigue, swelling that is getting worse, a new cough, dizziness from a low heart rate. These are signals, not inevitabilities. Report them. And every time you walk into an appointment, bring written questions. That is how you ensure the 12 minutes you get are spent on what actually matters. Everything we covered today is for your understanding and your education. Your situation is specific to you, and using this as a starting point for a real conversation with your doctor will always be more useful than trying to manage things on your own. And remember, that free cardiac screening link is still in the description. 30 seconds could connect you with monitoring and treatment options you did not know existed near you. Take care of yourself.